Dr. Aburashed is our corporate chief specialty services person. He's also our chief medical officer for the corporation as well. I've had the pleasure of working with him for 2 years now, and we've become very close. He's an excellent person, individual. He's got a lot of knowledge, and if you guys are here listening to the lecture today, please introduce yourself to him. He's an excellent resource for anyone to have. But I'll give it over to him right now to start.
Thank you, Ali. Thank you guys so much. Those of you who don't know, this morning I got out of my car. So I'm based in Michigan, right, which where Insight's headquarters is, and so for the corporate people, we tend to travel a lot. So Iowa, other hospitals that we're acquiring here, so on and so forth. So this morning I got out of my car in the parking lot, and Dr. Sagarwala, the pain doctor, was walking by, and he watched me get out, grab my briefcase, and suddenly go to the floor. And I couldn't walk at all, zero. I got an entire spasm on my right side. So luckily, I want to speak about how awesome this hospital is. So I hobbled in. I don't really have back problems. I just get a spasm once in a blue moon from driving or flying or whatever. And then I don't sleep very much. So those two things combined is not good. And then Walat doesn't feed me good food, so I'm poor nutrition. And so you add all those things up, it's a recipe for disaster. So I got into the lobby, I hobbled into the lobby, and Maria and Pearl were there. And so Maria, and I'm leaning on one of the tables like this, just trying to sort of get by. And Maria comes over and she said, "What's wrong?" I said, "My back's hurting me." She walks me, gingerly into a conference room, and she brings out what she called the Mexican version of Aspercreme. And she suddenly was like, "Come here, take off your shirt." And she starts massaging my back. And so for about 5 minutes, I'm trying to she feels me getting these severe pains. And then Vanessa, who helps me with everything, came down and saved the day. Dr. Sagarwala came, but it speaks to the people here, right? I sat in that room. They got me a wheelchair, got me to my office eventually. Now I've got about 20 milligrams of prednisone flowing through me. I've got 30 milligrams of Toradol, so now we can rock and roll and talk. In about 3 hours, I will not be able to move probably. So thank you guys. First of all, to the residents, welcome. It's so awesome to have you guys here. You don't know what it means and how much work went into making the residency come to light. It was a super, super heavy pull by a lot of people. Dr. Rizwan Mohiuddin, Dr. Asim Sayed, Yvonne, her team, Josh, that entire unit really did a lot of amazing stuff for you guys. Dr. Anjum, Dr. Alaga. So it's great just to have you guys here and to be lecturing, to have this auditorium active again after several years of it not being filled. One of the areas in this hospital that we have to, as a unit, get better at is ischemic stroke, okay? We are a stroke accredited center, but I can assure you if we do not improve as a group from now and actually take this seriously, it is going to be almost impossible for us to maintain that if only 1 or 2 people are focused. So my goal of today's lecture is to explain to you guys just, number one, an overview of ischemic stroke. I think there's a lot of confusion at what we should call a stroke, what we shouldn't call a stroke. People are sort of, timidly trying to toe that line. And so hopefully at the end of this, you'll have some clarity on whether you're a nurse, LPN, or a doc, on when you should at least consider a stroke. Because it needs to be an immediate, if it could be a stroke, it's a stroke first. And then the second piece is really from an accreditation standpoint, what are the key things we have to do as a group, both in the ER, as well as on the inpatient side, as well as on the discharge side, to maintain accreditation, okay? So with that, we begin. So what is a stroke? The brain is the most amazing organ in the body. I don't care if you like cardiology. I don't care if you like GI. The brain is the best. It really is. And I'll explain why. The brain is so meticulously built. The way the brain functions from an anatomical standpoint is really, for me, the infrastructure of belief in God. And the reason I say that is it's impossible to have this much complexity in one area that works in a way in unison. So everyone in the room, lift up your right arm. You lift up your right arm. Everyone in the room, in a millisecond, fire with your left frontal cortex, right? In a millisecond. Everyone touch your left arm. Everyone feels that sensation. In a millisecond, your body was able to use the right parietal lobe to tell you something's touching my arm, right? Instantaneous. Everything in the brain is upside down and backwards. The doctors in the room know this. You guys all did neurology, probably hated it. And that's why that's why you guys call me, because you're like, I don't know what's going on here. But the brain is incredibly intricate, but it's also organized. And to understand stroke, you have to understand the organization of the brain. I get phone calls all the time. I think this patient's having a stroke. Well, what are the symptoms? Well, I don't know. They're sort of out of it, you know. And I'm like, okay, so tell me what anatomical part of the brain correlates with out of it, right? Like, where is out of it? I told you guys the right arm was left frontal, the left arm touch was right parietal. Out of it is not really a symptom, right? Are they encephalopathic? Is there a metabolic abnormality? Are they confused in a different way? So the beauty of stroke, if there is a beauty, the beauty of stroke is that it's predictable. It's predictable if you know anatomy. So for the residents in the room, the medical students, understanding the basic anatomy of the brain will allow you to know what probably is a stroke and what probably is not a stroke from the minute it happens. So usually when you guys call me in a millisecond, I know this is vascular or not. I literally, in a millisecond. Anita calls me, I know right away. Anita, how many times I've been like, nah, it's not a stroke. No, I mean, all the time. Not because she's doing it correctly, because there's something, a question going on, and she wants to know, could it be, and should I be concerned about it, right? So let's walk into sort of how we do this and what it means. The key to a stroke, in order for it to actually be a stroke, it has to be a brand new neurologic symptom. I was fine this morning, suddenly I developed X, Y, Z, okay? So when somebody says, my right leg has been bothering me for a week or two, and it's continuing to bother me, and they got a little worse this morning, is that a stroke? No. Very unlikely to be a stroke in evolution for 2 weeks. Doesn't happen. So an acute onset neurologic symptom, and your next step as a nurse or provider is to think about where in the brain would a lack of blood flow cause this to happen, right? So what does it correlate to in the brain? So the body is, you know, life mimics art, right? So we all have pipes in our house. We all have pipes that flush the toilet with, the sink turns on, water runs down. What happens when a pipe gets clogged with hair? Ali knows this because he's losing his hair. So like a lot of his hair is going into a pipe. What happens, right? It slowly backs up, right? So you get a slow flow through that. So you turn the water on, the water starts dripping, and then you get a little bit of back, right? Maybe it's still going, but there's water back up, right? The entire pipe system is actually based in our brain, right? You look at the human body, you look at the brain. Everyone has obviously arteries that run through the brain, and we'll talk about those, the main ones to think about in stroke today. But those can get blocked. They can get slowly blocked. They can get rapidly blocked, correct? And when they get blocked, what happens? The water can't get past that blockage, right? The only difference here is instead of the water backing up being the problem, in the brain, if there's no oxygen getting to it, it starts to die. That's what a stroke is. You have a blockage of a pipe, and there's no blood going beyond that pipe, and therefore the brain tissue that pipe goes to is going to die. So if I have a blockage in my right MCA, okay, let me ask one of the interns, who I want, who wants it? Don't put it in. If I have a blockage in my right MCA, what would happen? Listen. This is when you don't want me to know your name, right? So one time you don't want me to know your name, right? I don't know everyone's name yet, so I just saw her. I know her. So let's think about it. Right MCA. So the right side of the right MCA supplies, start basic. The right MCA supplies the right or left side of the brain. What side? Right side. The right side. The right side of the brain, right? It's the right MCA. The right side of the brain controls what side of the body? The left side of the body, right? Is the MCA anterior or is it posterior? More anterior, right? It's part of the anterior circulation. Anterior is the motor cortex, right? So what symptom would we expect? Say it louder. Yes. You know, my favorite resident answer is like the sort of mumble. I'm not confident, but I'm going to throw it out because I'm answering, but I really don't 100% trust yourself. Listen, if you get it wrong, who cares? The patient's not here. There's a time to get it wrong. What would I expect in the patient? Weakness where? Left side, right? Perfect. Because the right MCA supplies the right frontal cortex. The job of the right frontal cortex is premotor and motor. Motor on the left side of the body. So I would expect face, weakness, arm weakness, leg weakness on the left side. That is a right MCA stroke. The best resident in the world, when they're PGY 3s and 4s, when I was at Michigan State, they would call and they literally would say, I've got a right M2 occlusion, right? Didn't even have to tell me the symptoms. They just knew from looking at the patient, it's a right M2 occlusion, right? So you have M1 and then it branches further. The pipe goes out, right? So once you understand and manage, the reason I'm hounding on this for the residents, it's the perfect time for you to review 10,000 foot neuroanatomy. You guys know it, but you're not confident. I can tell from your answers you don't trust yourself yet, which is good. You shouldn't be, but you will over time. As you get better, you'll start to trust and you'll realize that everyone's pretty stupid and you're pretty smart. So I think that's the approach you have to take with this. Nonetheless, pipes get blocked, no blood flow, we end up in trouble, right? All right. So when we look at the anatomy of the brain, what is this beautiful structure called, guys? The circle of Willis. The reason I put this up here is because this is actually the Insight logo. Okay? Everyone look at your jackets. When you look at your jackets, you'll see the Insight logo, right? If you have an Insight shirt on, right? The Insight logo is actually based on this artery right here, called the basilar artery. And does anyone know why? Trivia question. So the way Dr. Shaw came up with this years ago, it's a pretty cool story. So in religious tradition, it says God is closer to you than your jugular, right? That's sort of a thing that like you teach kids. Like your character is when no one's watching, right? So God is closer to you than your jugular. When you look at the translation, it actually is saying God is closer to you. It's actually jugular is two. It says a singular artery. That is the artery of life, right? The basilar artery is the artery of life. If this artery blocks, what happens, residents? Complete locked-in syndrome, right? The worst medical condition that can happen to a human being. Locked-in syndrome. What that means is if this artery blocks, right here, this pipe is blocked, the patient will present with the inability to move any part of their body, the inability to move any part of their face, with full cognition. All they can do is blink. And they're fully aware of everything around them for the rest of their life. It is the worst medical condition that I've ever seen. I've seen it twice in my career. One time I saw it when I was training, it was caused by a doctor. He was doing an endovascular procedure in Michigan, not Insight, before I joined Insight. He was doing an endovascular procedure, and let me tell you the story because it's a touching story. He was 75 years old. He came in for a TIA. His TIA, transient ischemic attack, was just, he would have episodes where he couldn't speak well, okay? We worked him up to figure out what was causing it, and he had a blockage or a tightening in the basilar artery. This was probably 15 years ago, honestly. This is when endovascular was just starting. He was fine. He was perfectly fine, happy, 80 years old, whatever he was. I'll never forget, I was a resident, I was at PGY 2, and I'm just sort of rounding and hanging out with the attending. And the attending says, well, we can go in there and put a stent in there. You know, we can put a stent in there because if this thing shuts down, you're going to get locked in. It's going to be a big problem, right? And the guy says, you know what, don't worry about it. I'm 80. I'm with my grandkids. How long will it take to get locked up? And the doc said, you've had this for years. It could be another 2-3 years, but it might eventually happen. When it does, it's going to be bad news, right? We can put you on some blood thinners, or we can do this. The guy says, I don't want to do it. I'm not doing it. He says, don't do a procedure. Just stabilize me, get me home to my grandkids. The wife says, you need to do this. I'll never sleep again, knowing it can happen at any time. So I need you to do this for me to sleep. He goes along with it. And this is a true story. I'll never forget it. He goes along with it. The doc goes in, does everything right, places a stent in, and he completely collapses the artery. The whole thing shuts down. On my life, he did not leave that table ever again. He was locked in until he died. He died probably within 6 months. But he was locked in. The last 6 months of his life, he couldn't talk, he couldn't speak, but he was aware of everything around him. All he could do was blink once or twice. You know, you couldn't feel anything. So you have to understand the gravity and the beauty of that, of something so terrifying, right? But also understand the responsibility for us as healthcare providers to be the damn best at what we do when it comes to this stuff. Like for the residents, you need to put that responsibility on yourself right now from the beginning of your training that I am going to be the best at this job. I'm not just, you got your residency, done. That was your focus, you needed to get in. Now that you're in, now we figure out what you are. And so, you have to be the best at what you do, because these terrible things happen, and they happen to everyone, and they may happen to me one day. They may happen to any of us, God forbid. Nonetheless, luckily the basilar artery is pretty robust. It doesn't close down a lot. The MCAs are very common areas of stroke. We see this all the time. So right side MCA, left side weakness, left side MCA, right side weakness, or numbness on the opposite side, either side. And then you have the anterior communicating artery and the ACA, the anterior cerebral arteries. And these arteries usually supply what part of the body? What is it? Medial frontal. So what anatomically, what is that? Symptom-wise. If I had an ACA infarction. Say again? Motor? There is motor, but what motor? What? Lower extremity, right? So only lower extremity, right? So these very rarely stroke. These are very rare. Most of your strokes are going to occur in your MCAs here. You can see it here in this MRA. Here's the vertebral here's the basilar artery, the one I talked about earlier, the most important one. It's fed by two arteries, the vertebral arteries. And again, this is beyond the scope of this lecture. For the residents, I will go into much more detail over the next year, doing individual vascular systems for you guys, so you guys really understand it. But this is an overview for the nurses, for everybody in the room to understand it. So, what causes this? Basically, strokes are caused by aging and living horribly. So, if you're hypertensive, diabetic, obese, if you drink alcohol, if you smoke, all these issues will increase your risk of stroke significantly, okay? So the reason I put this up is for the residents and for those the nurses discharging patients. You have to modify your patient's risk factors. You have to tell a patient, every patient wants a medication to solve their problem. That's the American way, right? We all do. Give me something that just solves my issue. That's not the case with this. We can give you stuff to help you. I can get you 35 to 40% there, but the other 60% is going to come from you. You got to stop smoking. You got to get in shape. You have to get your blood pressure down. These are things that you have to take seriously. The reason this is important, I see Scott Koppel back there. I see Rany Aburashed in here. Maybe Rashput's in here. There's primary care doctors in here. They are the most essential piece of this. Being able to actually, you talk about who prevents more strokes, me as a neurologist or Dr. Koppel? Dr. Koppel all day long, right? Dr. Torres all day long. Because those are the things that actually lead to what I see later in life. So as a unit, one of our goals as the collaborative initiative that Dr. Banis worked so hard to build and now is taking off, is to improve the quality of life and mortality rates in this area. In Bronzeville, guys, the average lifespan is 68 years old. Down by Northwestern, it's 83, okay? Now, you talk about healthcare disparity, there is no stronger indication. If someone's dying at 68 versus 83, 15 years of life, okay? Why is that? A distrust of healthcare, a lack of resources, a lack of education, and a lack of us doing the things we need to do as healthcare providers, as an institution, to actually tackle the things that matter, right? And these are the things that matter: hypertension, diabetes, vascular disease. So, for the nurses in the room, and this is the question I get all the time, how do I know if someone's having a stroke? When should I be suspicious if it's a stroke? Why wasn't the stroke called? Oh, I didn't think it could have been, okay? So I'm gonna break it down. You guys all know the BFAST thing, or the fasting, face, arm, sensation. Let's make it easy. Make it as easy as possible, okay? Everyone here is always looking for confusion with a stroke. That happens very rarely, okay? Confusion to me is like number 10. For me to understand something is stroke, if a patient comes in, and these are the questions you have to ask, okay? If a patient says, I don't know, I just feel weak, as a triage nurse in the ER, what's your next question? What should it be? You might not know yet. You're going to write down weakness, right? But I want you to go a step further than that. Where do you feel weak? My right side. This could be a stroke. As opposed to, I feel weak everywhere. Is it fatigue? Is it a UTI, right? So just that little question is going to change the degree to which you escalate your patient to a stroke. And we begin working quickly. Why is that important? Every second, with a lack of blood flow to the brain, 50 million neurons die. So 50 million neurons. Think about that number. We have billions. 50 million per second. So you can imagine delaying this by 7 to 8 minutes Not because the triage nurse is bad. They are just sort of operating in a different mindset. Oh, it has weakness in the thing. Anita sees it on her board. Oh, we got a guy with weakness. Maybe he's fatigued or something, or took medicine or something, right? She's not even thinking strong. We get the guy back. Suddenly he says my right side is weak. We've wasted 37 minutes. 37 times 50 million brain cells. You give me the number, right? Right. So your next question for weakness is, what is it, one side or the other? Okay. Number 2, numbness. Numbness on one side of the body or the other, you should trigger immediate stroke. So when someone says, I have a numbness in my arm or in my arms, immediately stroke. I don't care if we're wrong every time. I don't care if every single one goes through the entire protocol and is negative for stroke. I'll take every phone call. I'm down. But what I hate worse than that is when they have a stroke and it wasn't called. Because that's a tragedy. Okay? That's sad, and we shouldn't do that. So numbness, weakness. Number 3, when a patient comes in with vertigo, new onset vertigo. Okay? So if you develop the sudden onset of vertigo, it's probably not a stroke, but it very well could be a stroke. So you always err on the side of caution, right? Probably something like benign paroxysmal positional vertigo. We see it every day. It's not a big deal. We send them on their way to rehab. They're fine. But in the event that it's not, it's a posterior circulation stroke, right? Cerebellar involvement and for the residents. So you got to take vertigo seriously. For me, the things that I take the most seriously in my day-to-day life is numbness of the face and new onset vertigo. Those 2 things for me are like big, big things. Whenever a patient says that, immediately I know I have to do something. This is not BS, they're not making it up. It's not, right? And if they are, great, we'll deal with that after. But for the time being, this is very serious. So those are the big ones. And then the 4th one is speech. If someone's speech is garbled, right? If someone's speech is garbled, where they can't sort of, they stumble on words, right? You might think they're drunk a little bit, right? Sounds sort of like they're drunk. Or if they can't get words out correctly. So for the residents in the room, let's do another trivia question because I love the Socratic method of teaching. So if a patient has a stroke, okay, so what side of the brain controls speech? Someone said left, right? Be confident, just say left. If you're wrong, you're wrong. 50-50 shot. That's the question to answer. You got a 50-50 shot because they're going to get harder. The left side of the brain controls speech, right? So there's 2 areas that control speech. What are they? Okay. Broca's, which is anterior, right? Broca's, Brodmann area 22. And Wernicke's, which is posterior central gyrus, which is Brodmann's area 44, right? What connects those 2 areas? The artery-fasciculus, someone said. I think Ali Medhouse said artery-fasciculus, right? No, who said artery-fasciculus? See, kudos, that's good stuff. Now let's go a step further. So Broca's area. Broca's area does what? Remember, this is left MCA, okay? A left MCA stroke is going to cause Broca's to get shot, essentially. And it can also cause Wernicke's to get shot. So Broca's area controls what type of speech? Expressive. So I'm talking right now, my Broca's area is over and over again, right? Millions of neurons are just shooting from this 1 little millimeter right here in my brain, okay? That's my ability to produce language speech. Wernicke's area does what? Receptive. You're listening. So for you, everything I'm saying is going into Wernicke's area back here, right? So it goes to Wernicke's, and then what happens? It transmits it to Broca's through the artery-fasciculus, and then you answer my question. Look how incredible that is, guys. Like how incredible, like if you can't be excited about like this piece of anatomy, I don't know what to tell you. Like that, to me, this is like when I first learned this, when I was in med school, I was just like, this is insane. Like this, and no one understood it, and I didn't understand it. But I was like, this is the coolest thing in the world. Like this is what I have to put my life into because it's just amazing. You can't design it, right? And so, and it does suck because anytime I'm on the phone, I think about these things consciously, which is kind of hard, right? But still, it's pretty amazing, right? So if somebody comes in with the symptom of difficulty speaking, and it's a stroke in Broca's area, how will they present? Yeah. Yes. So for the triage nurses in the room or anyone in the ER, when someone cannot get words out, when their speech is broken, stroke till proven otherwise. Doesn't matter. Okay? When someone's speech is heavily slurred or garbled, stroke unless otherwise noted. And when you give them directions, can you fill this out? And they're like starting to speak. What happens with a Wernicke stroke? What do they make? Remember the boards? Word salad. So if someone has a stroke back here, you know how they talk? You'll ask a question. You'll say, Randy, what color is your jacket? And I'll say, letters 1, 4, 7, bus. And I'll think I'm answering correctly. Right? It's called Wernicke's technique. So it's called a word salad. So as a triage nurse, if you don't see this, you might think they're just on drugs. Or they're crazy. They eat cider. Right? But that's a stroke. So that patient immediately goes into stroke protocol. Okay? So the stroke warning signs, this sort of goes into what we talked about earlier. I'm not going to spend too much time on that. And now the functional areas of the brain and why they matter. So this is the coolest slide. I love this slide because I think if you're not into neurology, it sort of shows you, from a 10,000 foot room, if I was a nurse and I wanted to learn stroke, I would take this picture and I literally would put it on my desk. Not because you have to memorize it, because you can look at a variety of symptoms and somebody comes in and says, this morning I went to go grab the remote and my hand I couldn't find it, right? I was incoordinated. I lost coordination. It at least will trigger a thought. Could this be a stroke in the area that controls coordination? Cerebellum. If somebody comes in and says, I couldn't see, sudden onset of vision loss, could this be a stroke right? We always think eyes. Everyone does. Something's wrong with their eyes. Something's probably happening in the brain. So always err on the side of caution, right? So when you understand that. Parietal does sensation. Temporal does memory more than anything. Doesn't really stroke very often. And then we talked about a lot of the other ones. So this is that area I was talking about, Broca's area here. You guys can see it. This is where you produce language. This is where you take in language. And then our esteemed colleague mentioned how they're connected through this beautiful fasciculus called the artery fasciculus, and that's how we communicate with each other. So any area of the brain can be affected with a stroke, but some are more common than others. Again, that's too much data. So what is our goal? Our goal in this hospital is to get a patient door to needle. This says 60 minutes, but this is old. Our goal is going to be 30 minutes in this hospital. Okay? We're going to be ambitious, and it's going to be 30 minutes. This begins in the ER. The ER is the most important component of this. So I cannot stress to the ER nurses, ER physicians, triage, the techs that take patients to CT, the techs that run the labs down, the pharmacists that get the TPA ready. 30 minutes is our goal from door to needle. Okay? So what does that look like? A patient comes in by ambulance. Comes in by ambulance. I can't read the times here, but in the first 10 minutes, that patient from coming into the hospital, whether they walk in through triage or in the EMS, in the first 10 minutes, what I want done is the following. That patient should be vitaled. Their glucose should be taken on a glucometer and written down in the chart immediately, right? Or you write it in later and you put down the time you took it, not the time you ordered in, right? Very important. Glucose is done right away. The patient is immediately taken to CAT scan for their scan, and the doctor or the PA or MP immediately does an evaluation, a fast evaluation, checking for a neurologic examination before they get to the CT or on the way to the CT. So it's actually better to walk with them to the CT and do your exam. I'm being honest, like that, and we can do that right now in our body. So I'm going to call up 2 people. I'm going to call up. I already picked on you. I need 2 residents up here. Come on, don't be shy. I'm not going to embarrass you too much. It looks good if you say I want to do it. All right, give me 1 resident. Come on, man, soft. You ready to call on you? Come on, I love it. Come on, you love it. I love it. There you go. Confident. Okay, and now I'm going to pick on Malik because he's new. Malik, come down here. We'll give another resident a day off. Malik, the good news for you is you don't need this medical knowledge, so you're in good shape. All right. So, how are you? Good to see you. Okay. So, what I want you to do is I want you to show me on Malik a quick neurologic evaluation. And then we're going to expand on it a little bit. For the nurses in the room or the triage nurses, I want you to see how I do a neuro eval after him if I think it's a stroke. Okay? So why don't you do that? Okay, so he said smile. You can keep going. Smile, shrug your shoulders. Okay, sensation of it. All right, what's he checking with us? Cranial nerve. What part of the brain? Right now he's checking the brain stem, right? It's all brain. Okay.
You can kind of hearing, but you can't really.
Yeah, that's fine. You did it. That's good. All right. So, failure, perfect.
You can listen for resistance. If I go in, go out, if I go out, go in. If I go down, go up. If I go up, go down. The legs don't do the same. You do like kick out. Okay, and then go out. Go in the resistance.
Okay, so he's checking motor now, right? He's checking side to side. Right versus left. Is one side bigger than the other, right? So the triage nurse, you can do this at registration if you need to. If somebody's there and you suspect, you literally can say, stick your tongue out all the way. Is it going left or right? That could be a stroke. You know, if their face is drooping, it could be a stroke. If they say I have double vision and their eyes look a little bit wacky, it could be a stroke, right? So he's doing a quick brain stem evaluation. Then he looks at the motor symptoms of the body, right? He wants to see their weakness on one side, comparing right to left. Keep going.
And I'll kind of check for sensation. So maybe tell him to close his eyes and tell him where I'm touching on his left leg.
So sensation, so he's going to check side to side. Is one side lost sensation?
I'll try to think of a pronator drift. I forgot how to do it.
Okay, good. I'll show you in a second. And then what else would you do? What's the most important piece of this that you don't miss a cerebellum?
Maybe tell him.
So dyshypokinesia, heel to shin. What else? Okay, those are great. Yeah, so finger to nose. So dyshypokinesia, nose to shin, heel to shin. I'll do that in my clinic. When I'm evaluating for a stroke, I ain't doing that. I mean, I'm just not. The reality. And I'm not checking here, right? Those are corners you're going to cut until you're doing an NIH stroke scale, a full one. So you did a good job. Give him a round of applause. For the residents, anytime you get called, just come. Because I swear to you, the norepinephrine that you get from being scared and the mistakes you make will make you sharper in code. It'll make you sharper later in your life. You'll see. So take the lumps now, right? That's my advice. If I'm looking at a stroke, guys, and I'm a nurse, or I'm a resident, or I'm a ER guy, my scan of a stroke patient is going to be about 3 minutes total. Literally, it's going to be a 3-minute examination. Okay? Smile big, stick your tongue out, put your arms down in front of you, turn them over, close up in front of you like this, turn them over, close your eyes, turn them over again like this. This is called pronator drift. This is the most subtle sign of cortical damage. If this arm drifts, it could be a stroke. That's it. If it drifts a millimeter, it could be a stroke. The most subtle sign of weakness is this arm drifting right now with the eyes closed, right? Touch your nose, touch my finger, good. Touch your nose, touch my finger. Be able to do that without missing my finger. Cerebellum looks good. Okay, bring your leg up like this. Bring this one up like this. Okay, can you walk for me? Take a few steps, good. Do you feel me touching you here? And touching here? Does it feel the same on both sides? Okay, good. Cool. That's my exam in a quick ER visit stroke. That's it. And if there's any asymmetry, immediately to stroke. Okay, so asymmetry, lateralization. Thanks to Matt. Give Matt. So don't overthink it, my point. Don't overthink it. But if it's lateralized, get them to the CT. That's it. Next thing going. All right. So in the ED, vitals immediately, glucometer, labs, PT, PTT, INR are essential. CT, CTA immediately. I always recommend a CTA with the CT. No matter what, I'm going to recommend you get a CTA. So what I would tell the ER is just do it. Like I'm going to want it no matter what, right? That the CTA looks at, I'll show you why I do that. And then most important, the time of symptom onset. This is what we sometimes slip up on. When did the symptoms start? Get as specific as you can. You know, who last saw you normal? When did it start? Where were you? What time were you there? Is there a text message on your phone from when it started? Is there what were you doing? Get as detailed as you can with time of symptom onset, because that's going to be critical for what happens next, right? So, okay. So why CT, CTA? CT, non-contrast CT, fastest way to rule out what? A bleed, right? The reason we're doing a CT is not to look for a stroke. It's to make sure there's no bleed in the brain. There's a patient right now in 712 who I just saw who came in after a traumatic fall being drunk, and he had what? Who's seen him? What team? Someone's got to memorize their patients better. Intraparenchymal, 1 centimeter intraparenchymal bleed was subarachnoid, right? We saw it on his CT immediately when he came in the ED. It's not a stroke, right? A stroke is not what I'm looking for. I'm looking for a bleed. All I want to know is there a bleed plus minus? Yes, no. Then, if you see a stroke, fine. say we see a stroke or an evolving stroke. What I actually want to hear is there's no signs of stroke, because that means we're early. Okay? The stroke appears later on the CT, not acute. It appears immediately on an MRI. So on a CT, I hope you tell me it looks clean. That's what I want to hear. It looks good. That means I got a chance, okay? Then I look at the CTA. And what I'm looking for on the CTA is which pipe is blocked. This pipe right here is blocked. You guys see that? That's an MCA stroke right there. And look at the correlating territory. You guys see that? So this pipe right here is not getting blood flow. It should look like this. But it doesn't because of the big blockage there. This is a CT perfusion scan. This shows you that this area is dying. It's not getting blood flow. Everywhere else is flowing beautifully, right? Reds and greens and yellows. This area is blue as the sea. This is bad news. This person's in big trouble. If we don't open this blood vessel, this is all dead. Right now, a lot of it's dead already. But if we don't open it, it's all dead. And so that's why CT-CTA is so important. And so for the residents, a lot of the residents, last time I was rounding, they asked me, there was a TIA patient, right? I don't know what team it was. And they said, we're waiting for discharge for the MRI. And what did I say? Who was there? I remember? I said, why do we need the MRI? I don't care about the MRI, right? He had a TIA. He had looked like a stroke, and it went away in about 30 minutes. Much more meaningful test to me in that patient is the echo and the CTA. The MRI is not going to tell me anything. The MRI only tells me something if I think it is a stroke, right? And I'm not sure. Let's look. The MRI was very sensitive for stroke. But again, I want to challenge your notions that if they have a stroke, they need an MRI. It's plus minus MRI. What they need is a CT, CTA, and an echo. That's what they need before they leave this hospital, no matter what. Okay, and a telegram. Okay. So TPA, or the clot busting drug, is something that you all have to be familiar with, especially on the floors at night. If you're a resident and a patient develops new onset neurologic symptoms, this is your baby. You are either going to save their brain or not. And in the ER, this is what comes in every day, right? So if the symptom onset is within 4.5 hours, they might be a candidate for TPA. Okay, I'm going to give you the bare bones TPA lecture, so you guys at least have something in your back pocket that you can use should you see anything, God forbid, on the floor. Okay. So TPA, ideally administered within 4.5 hours. Some cases can be treated later. So I want to know about these cases immediately. You're going to call me right away, okay? If they're possibly here. So what are the guidelines? Number one, confirm ischemic stroke via neuroimaging. Is that correct or incorrect? It's incorrect completely. So I put it up there to see if anyone would call me on it. Because I just told you MRI is not needed and that the CT should be clear, right? But in most residents think, let me find out if it's a stroke before I give them TPA. The mindset is complete opposite. If I suspect it's a stroke, it's a stroke. Give them TPA. Yes, there's a 4 to 5% mortality if it's a significant stroke, right? So Anita calls me a lot for these. So she calls me and says the patient has some left arm numbness only. Do you think you want to give TPA? And I say, always, how bad is the numbness? So in my head, I'm like, okay, it could be a stroke. Probably not, but could be. And then how bad is it? Go ahead. Well, you're always going to get a CT to make sure there's no hemorrhage. So you never give TPA until the non-contrast CT is done. Yeah. So every stroke protocol, before giving TPA, you will have a CT no matter what. Please don't give TPA without a CT. Because that patient in 712 would have bled out and died in about 5 minutes. There would have been bad news, God forbid. So it's a good question. So Anita calls and says, the left arm is a little bit numb. And they started an hour ago. Right? Do you want to give TPA? I always ask how bad's the numbness. And if she's like, it's just a little bad, I'm like, don't take the risk with TPA. Because there's a 5 to 7% risk of mortality with it, right? It's just numbness. Even if it is a stroke, it'll probably get better. Because their NIH stroke scale is too low, right? But if someone says they're weak or they can't talk, right? So look at the symptoms. If the patient has significant symptoms that would alter their quality of life, err on the side of giving TPA, not the side of not giving it. Don't be scared of TPA. Okay? Many people are scared of TPA. At least training you are, and a lot of nurses are. So they always err on the conservative side, like, oh, I don't think he needs it, right? Oh, this is a big ER thing. Who cares? Give it to him. I'll give TPA in a second. I'll run downstairs right now in a half a stroke, and I'll give TPA if I think it might be, right? Because that gives them a chance at life for the rest of their life. If it's a significant symptom, give them a chance, assuming they don't have contraindications. So age greater than 18, Blood pressure 185 over 110 or less than, and then obviously no recent surgery, trauma. So you got to get a quick history from the family or from the patient. Contraindications, as you mentioned, hemorrhagic stroke or unknown type of stroke, recent surgery, trauma, and then active internal bleeding. So you want to make sure your labs are back. That's why I told you guys in that first 10 minutes in the ER, I want the lab tech to get the labs to the lab. I need to know what the hemoglobin is before I do TPA. I need to know what the glucose is before I do TPA. I need to know what the CT is before I do TPA, right? That's why when we stress these systems of 10 minutes at a time, busting through all these barriers, there's a reason for all of it. It's to get to the right thing for the patient. PTT, INR. I can't give TPA until I know that number. So I need that number. We have to work aggressively as a team when it happens. And it takes everyone. So we're going to do a CBC, a coag panel, a lipid panel eventually on the floor, a basic metabolic panel, and then everyone should get a hemoglobin A1C, right? This is the stroke workup that everyone in this hospital has to have done at some point during the stay. Most of it's in the ER, the hemoglobin A1C, residents. Hemoglobin A1C, fasting lipid profile on every TIA or stroke on the floor. Has to be done. Get it, document it in the chart. Hemoglobin A1C 7.2, LDL, cholesterol less than 100, all right? Because my goal is less than 70 LDL, and my goal A1C is less than 7, right? Long term. That decreases their risk of stroke by 20% again, if I can achieve those two goals, right? So, had to have those done. For the nurses in the room, in the ER especially, we've done a subpar job of documenting glucose in the ER. It's what's happening is we're checking it, or we're checking it and a day later writing it in the chart, or 3 hours later putting it in the chart with the time of 3 hours later. And so when the stroke body comes and says, your glucoses are an hour and a half after onset, why is that? We say, no, we checked it when they came in. They just put it in the chart an hour and a half later. No, put it in the chart with the time that you checked it. So if you're on the floor and someone strokes tonight, and you're going to bark off some orders, you're going to say, let's get them to CT, get a glucose check on them, right? Why are they acting weird? Get a glucose check on them. It's got to be documented, guys. And then you sort of go from there. The reason for this, the reason it's so important to understand this, guys, why TPA is so important, is when you have a stroke, you have a central core, an area that's dead, okay? That's dead. It's not coming back. The pipe is blocked. That area is done for. But around that area is the ischemic penumbra, okay? The ischemic penumbra can last up to 24 hours. So for the next 24 hours after that blockage, there's continuous damage occurring in that brain. And so when you give TPA, you break that clot, you save all of that surrounding tissue. And it means the patient has a chance to improve. So don't look at a patient with a left MCA who's weak on the left and can't, left MCA and can't speak, weak on the right and can't speak. Don't look at them like, oh, they're too far gone. No, because that penumbra is going to, over time, with rehab, it's going to regrow. It's going to move around that dead tissue, that necrotic tissue, to give this patient a chance at using their phone again, a chance at switching the channel on the remote or feeding themselves, right? So they might not be perfect. They're not going to be normal again. They had a big stroke, but that little thing is a massive thing. Everyone in here is holding a phone. If a patient's a quadriplegic in a wheelchair, and all you can get back for them is the ability to lift their wrist and move their thumb, you have changed their life. You have changed, now the whole world at their fingertips. They can at least read. You can put an iPad in front of them. They can call people. They can text people. You've taken communication back to their life. So they start thinking like that as a clinician, right? Not, are they perfect? They're not going to be perfect. It's not a perfect world. It sucks sometimes. So on the inpatient side for the residents, the things that I want you guys to always have, and I'm going to summarize it at the end, what I want in the chart, what I'm looking for in the chart from the notes, and what Jen's looking for, right, in the chart. One, make sure that we've looked at the blood vessels. So this is usually done in the ER. If it's not, I want to know. So if there's no CTA done, sometimes it's not done, order it, okay? Two, you might consider a Holter monitor if you think they might have a cardiac history, okay? Those are the two that are kind of peripheral that you should think about. You don't need it. You need tele, but if you think it's an arrhythmia or paroxysmal AFib, you might do a Holter monitor. Documentation-wise, every stroke patient needs the following on the chart. Number one, did you consider an antiplatelet? Yes, no, and if no, why not? Okay? Number two, are they on statin therapy when they leave the hospital? Right? I want every stroke patient on a statin with a goal LDL of less than 7. You have to document it. This is what the stroke accreditors are looking for. They want to know antiplatelet, statin. Number three, is there a hemoglobin A1C documented in the chart? right? Did you actually do the test? Number 4, did you consider ordering PT and OT? You have to write it. PT, OT considered, not necessary, symptoms resolved, right? That's all. Just writing that means you consider it. So that's what a stroke accreditation is looking for. The next number is dysphagia evaluation. Everyone has to have a dysphagia evaluation, bedside, not a full one. Don't send them to radiology, but just a bedside to swallow. You just tell the nurse, did you do a bedside swallow on the patient? Did they swallow correctly or not, right? Can we feed them or not? You have to have that documented though, not just we did it and we didn't write it. Write it down. And there are stroke order sets that Dylan and Trina and team spent hours working on that are in Cerner for you to make this easy, right? In the ER especially, and then also on the floor. And then lastly, did you consider an anticoagulant? And if so, why or why not? Anticoagulant started, Xarelto started secondary to atrial fibrillation, right? And then the workup itself is simple as can be. CT, CTA, usually done in the ER. From your standpoint, echocardiogram has to be done. Most important test I want on the floor, right? I want an echo. They're not going home until I get my echo. That's the key, because the last thing I want to do is send out the active clot. And that's going to change my management. So I don't want things that don't change my management. Think about, whenever you're ordering a test, think about, does it change the management of what I do? An MRI in a patient who has a normal echo, I'm going to put them on antiplatelet either way, whether it's a stroke or not, whether it shows up or not on the MRI, unless you think it's a tumor or something else. But does that make sense? So when you're ordering tests inpatient, be deliberate, guys. Don't let these people sit on the floor for 4 or 5 days. The job is to get them in, stabilize, make sure nothing life-threatening is happening anymore, and then get them to rehab or home so they can get better. This is where they get worse. Every hospital in America, right? So a lot of people think we're going to hold on to them more days. More days is like the worst thing for a patient. So don't order an outpatient workup on the inpatient side. Say we're going to get an MRI, but we can do it in 3 or 4 days as an outpatient. Saddam Mahmoud's team will set it up. We'll get it done. Sada's like, dang it. Like IC3 will call you, or follow up with Dr. Koppel or Dr. Rany or whoever else, right? And so think about that. For a stroke or TIA, CT, CTA done in the ER, get to the floor, hemoglobin A1C, fasting lipids, consider anticoagulation if you need it, meaning they have AFib or a dissection on the CTA. Get an echo, get PTOT involved, get them on their way, right? Get them to inpatient rehab if they're bad, or so on and so forth. And then lastly, for when you go to your resident clinics, up to 40% of patients may experience a second stroke within 5 years. So managing secondary stroke prevention is how we're going to bring up this community. I'm almost done, guys. I know it's getting long. It's how we're going to bring up this community. So I want you guys to understand your goals with your clinic patients, whether they had a stroke or not. These are your goals. Target blood pressure less than 130/80. Lifestyle changes, put them on antihypertensives. If they have atrial fibrillation, you got to put them on anticoagulation. If they have hyperlipidemia, you got to put them on statin therapy with a goal LDL of less than 7. That's the goal. If you give them an antiplatelet, okay, here, my last trivia question. If a patient comes in with a stroke and they weren't on aspirin, for example, and you add aspirin, by how much do you reduce the recurrence of a stroke in that patient? Is it significant or not? How much do you do? 5%, 10%? Almost 20%. Roughly 20% just by adding aspirin. Doesn't mean they're not going to have a stroke, but you brought it down by 20%. Okay? What if you put them on statins and their cholesterol comes down less than 70? How much more percent do we get? About 20 more percent. So now we've reduced their risk by 40% just by doing it. If we get their sugar down to less than 7, you add another 12% reduction. If they quit smoking, you add another 20% reduction. You see what I'm saying here? You get their blood pressure controlled, you get another 10%, 12% reduction. So this is the idea. It takes the continuity of all of it to get them to prevent a stroke. And that's why when they leave here, they have to have this stuff done correctly. And so with that, I'm just about done. Diabetes, I talked about all these. And with that, I'll stop. And if you guys have any questions, please feel free. And thank you guys for hanging out. I really appreciate it. Go ahead. I'm a cat.
Yeah, so we don't do an MRI, so when do we do an MRI?
So an MRI is plus minus. If If you tell me I can get an MRI in the next 10 minutes and you're on the inpatient side, fine, take an MRI. All it's gonna do is make you feel better. It's not gonna help the patient. You're just gonna be like, oh, look, they had a stroke. I thought they had a stroke. I was right, yay. Right? I was gonna put them on aspirin anyways, but that's cool, yay, right? The CTA is a must, because if there's a blockage in the pipe, we can do something. And the vascular, even if it's transferred, if it's within 6 to 8 hours, we might go in there with the catheter, pull it out, right? But the MRI is simply, I use MRIs when I don't know what's happening, right? When I know what's happening, I don't waste an MRI. Okay, does that make sense?
Yeah, that makes a lot.
On the outpatient side, I use MRIs on almost every patient. It tells me a lot of information. On the inpatient side, an MRI is sort of pointless. A CAT scan or a CTA is much more meaningful. In fact, the echo is the most meaningful. You know what I mean? Yeah.
In case if patient has AKI or CKD, what will be the recommendation for CT angiogram? Because sometimes some physicians hesitate.
It's a great question. So a patient has kidney injury, and I'm telling you to get a CTA. And the doc's a little bit hesitant, says, oh man, I don't know if we can get a CTA, right? This is a real problem. So how would I approach this? 2 ways. Number one, our radiologists do have an AKI protocol where you can pre-treat with steroids. There are things you can do to get the kidneys right for a contrast. The reason you don't want to do this, those of you who don't know, is contrast on a patient with low kidney function can cause significant damage and shut down the kidneys. You don't want to do that. The other option, which is less desirable but doable, is a time of flight MRA. So it's called a time of flight MRA. You can just write MRA brain, head and neck, and I can tell the protocol. But I'll sometimes tell the team to do that. The other option, which is probably the better option, in this case, is going to go with the faster option, a carotid ultrasound, and have them go as high as they can. And sometimes we'll see enough in the internal carotids and further up. But it does limit you a little bit. So you have to just play that, you have to sort of manage that. Talk to nephrology, say, what can I do? If I have to do it, can you dialyze me tomorrow if I need to? Okay, I mean, that's the conversation out there.
Carotid ultrasound is more for the CKD patients,
Yep.
have a low GFR.
The ultrasound, you're saying?
Yeah.
Yeah, if they're really CKD and they're going to be dialyzed, I would just do the CTA anyways. Like CKD, chronic kidney disease, stage 4, getting dialyzed Monday, Wednesday, Friday, do a contrast CTA all day long. Just dialyze tomorrow. It's the ones who are in between, who are not on dialysis, that you're more concerned about, because you can exacerbate their cases. You know what I mean? So, but your other tools in your chest are an MRA of the head and neck, or a carotid ultrasound. Those are your backups to looking at the vasculature. Other questions, guys?
Do you recommend, on the same line, do you recommend giving the patient IV fluids before giving contrast? Because anyways, you have to maintain the blood pressure if it is an ischemic stroke.
Yeah, so it's a good question, and actually there's a piggyback that we should talk about for you guys. She asked about giving IV fluids before they go to the CT, right? Now, I just basically say start the normal saline and just let it run. I don't care how fast it's running. Because usually in a stroke, when they come in, what is the blood pressure doing?
It's permissive.
It's usually elevated, right? Why is it elevated?
Because the brain is getting enough blood.
But look how amazing that is. Look at what God did. This is incredible. I'm saying, when the pipes are blocked, what does God do? What did God put in the body? Naturally. He naturally elevated the blood pressure, right? We're blocked, let's push blood as much as we can. What do? Oh, his blood pressure is too high, I'm panicking, oh my God, I gotta treat this. No, don't treat it. Let it push, let it go high, let it push blood through that blockage as much as it can. Unless it's above 220 systolic, I don't care. Let it run for 2 to 3 days, it'll run high. 185, that's his body, that's the body's natural ability to heal itself, right? And so, there are cases where people will too rapidly decrease blood pressure in a stroke patient, and it hurts them a lot. I've seen this many times at every institution. It happens all the time. For blood pressure above 220, you do have to treat. That's too high. Now you're getting a hemorrhage, right? You don't want to hemorrhage. So above 220, you want to bring down very slowly. Over the course of 24 hours, don't panic. Don't freak out about 220. If we start working out right now, some of our blood pressures are going to be 210. Don't freak out. Body's okay. And then I think, so let it run high. 160, 170, 180, I don't care. The only time I would treat it acutely is TPA. I tend to bring it down to below 185 systolic, and I want the diastolic below 110. And then I usually will give TPA. Because that's too much pressure with a sudden break of the clot, and now you have like way too much thin blood going. By the way, those of you who don't have aspirin that I talked about, all we're trying to do is thin the blood a little bit, right? Because if I have a blockage in my pipe from here, it's easier to pour water across it than pour honey across it. So you just thin the blood with an aspirin every day. It makes it thinner, and it can get through those little nooks and crannies to the brain. And some things make it thinner than others. Aspirin, Plavix, Agronox, Coumadin, Xarelto. There's a continuum of thinning agents. So that's what you're choosing, is how am I going to thin this fluid? I want to thin the blood enough to get past the blockage. All right, any other questions, guys? I think with that, I'll stop. I think our esteemed leader on the ground, Ali Mehta, wants to come up and say a couple things. Thank you guys so much. I hope you have a great